Hello, my name is Ahmed Ghazi. I'm a professor of urology at the Brady Urological Institute at Johns Hopkins University, also director of robotic surgery and minimally invasive procedures. Today, I'm actually going to demonstrate a transperineal biopsy using the TP Pivot Pro device, which now is really the device that I use for all my biopsies. Here at the Brady Urological Institute, I perform around 15 to 20 biopsies a day. And truly incorporating all the different aspects of what we use, including the Pivot Pro, has really allowed us to perform these biopsies both efficiently and safely for the patients. So the model that we're going to be using is a transperineal model that is developed in my lab, which I direct. It is the Surgical Learning and Innovation Center of Excellence, known as SLICE. It is an award-winning model, actually modeled after a patient's MRI. It has realistic feel and is, we will demonstrate here, allows us to truly go through the teaching points of how we would do this. We are also using today BK Specto ultrasound. This is it has a transperineal probe and it's biplanar. I've used a majority of these ultrasounds before. They're very well high definition and also can be used with a targeted biopsy. One of the things that I want to be stressing and demonstrating today is doing this under local anesthetic. Now, the majority, about 80% of my patients, perform this procedure under local anesthetic. I do consult the patient telling them that there is some discomfort involved, and it's like going to the dentist because we do block the pain receptors. However, they do feel quite a bit of pressure. And this is where really the Pivot Pro is truly a huge value, because the pivoting technology itself allows you to biopsy the entire aspects of the prostate through one incision with minimal deflection and torquing of that ultrasound, because the patients do feel that. Some of them are very stressed and they are clenching down on that ultrasound probe. And when you start moving it, that causes more discomfort. As for patients that would do this on the MAC, or sedation, it is available at our institution. However, I really limit that to patients that have 3 or more target lesions that need to be biopsied, and I take an average of 2 to 3 cores from those, so that significantly adds to the 12-core template. Patients that are on active surveillance that require regular and frequent biopsies, or a patient that had really a negative experience with a previous biopsy. So no matter what you do, they are going to continue to feel pressure and pain and anxiety with this. If you follow the steps that we're going to demonstrate today, and they're very simple steps, you really will be able to do a significant number of biopsies with very little discomfort to the patient. But you have to premise to the patient, this is not a painless procedure. There's quite a bit of discomfort associated with it, but not one that would require anything beyond local anesthetic. The template I use is the music template. And for that, we do a paraurethral apex, a paraurethral base, a posterior apex and a posterior base, a lateral, and then an anterior. And you'll see the value of the Pivot Pro being able to not only get the peripheral zone, which you can do with really any transperineal obturator, but you would be able to go as far lateral as you need to go, as far anterior as you need to go, with very minimal deflection of that ultrasound probe, like I mentioned before. There are many ways of using it. There are many ways of being able to shift the different categories. It's a very versatile product. And here I'm going to demonstrate my technique of how I'm able to do it. This is the TP Pivot Pro that we're going to be using. Okay, it's actually comprised of 2 different parts. So you actually have the needle, and then you have the applicator that you place on the ultrasound. Now, you will probably have this already set up on the ultrasound when you come in your biopsy suite, but it's preferable to know how this is set up, because minor issues with this placement can really lead to difficulties in the biopsy. All right, so just to give you an idea, it has a couple of controls to it. So this is what kind of snaps onto the ultrasound, and then it's tightened over here. This, however, is really where the value is. You see there are different kind of steps of where you would have it. All right, this corresponds to where the actual needle is entering. You adjust this by loosening it up, and it's very easy to loosen it up. You can actually do it with one finger, and then you pull back and you adjust it on where you want it to go. So it's going up and down, and then you just need to snap it in to fix it and then tighten up this knob here, okay? I like to put it really either 3 or 2. I didn't go above that. And if it's a larger prostate, you can imagine larger prostate, you would need more room to pivot down, right? So you'd need to go a little bit higher up to get to that large prostate towards the anterior zone, okay? You can also kind of get it down and then move it up. I prefer to keep it in one location and then use this pivot as going up and down. So if you're not sure, start with the middle, which is third up, third down. That's exactly where it is in the middle, and start with that position there, okay? Placing it on the ultrasound is something that you have to check at least, okay? So this is how it snaps onto the ultrasound, right? You just basically snap it on, okay? And you can see it snaps on, and then you turn it and then tighten it up a little bit, okay? And this is how it tightens. Make sure this is nice and tight so it doesn't roll with you like other types of applicators roll on you. This really stays put the whole time. One of the things I like to do, and if you look at this, it's kind of off center, right? See where the middle is here and see where these buttons are? It's off center. So you're not going to be able to see your needle. So what I do is as soon as I grab the ultrasound probe while the patient's being seated and their scrotum is being pushed up, I like to take it and make sure it's perfectly aligned with it. So I give it a little bit of a turn and kind of really do an even aiming test to make sure it's perfectly where I want it to be, okay? These 1 or 2 millimeters off sometimes make you not see the needle the whole time. And with the minor adjustments we're going to make, which is really leaving it free in real time, doing those movements, you're going to get 1 or 2 millimeters where the needles are off. So you need this to be perfectly central, okay? So this is all set up. Now, the needle goes perfectly into this hole. Now you realize the needle has a cap to it. I would advise you to keep this cap on until it's handed over to you. This is a nice way for your assistant to kind of hand it to you and you pull it out. And when you pull it out, make sure the bevel is on top, and that's how you're going to insert it, okay? And so if we look at how we're going to insert it, it's perfectly into here. You're going to feel a little bit of resistance, a little bit tight, but that's good so that the needle stays put, and then you kind of punch it through, okay? All right? So this is what we're going to do when we place it inside the patient. So I'm going to take it off now and actually put this cap back on because that's how the assistant's going to hand it over to me, right? Okay, now doing the biopsy, again, looking at this model, you have the pubic bone right here, you have the rectum here, you have the median raphe, and this really represents the thighs. This is, of course, a patient with a low BMI, but our focus was really getting the internal structure very ultrasound agnostic as averse to really making the outer part too bulky. So this is all you need to know from a representation of what you're going to do. As you add the lubricant, I like to put some of this on my finger. So say I have the patient, the scrotum is really taped up. We actually use a tegaderm. We found out that's the best way to tape up any scrotum. And then we prep the area, the perineal area, okay, with chlorhexidine, wait until it dries up, and then we start our biopsy. So no pre-op antibiotics needed. You just need to prep the perineal area. I start off with putting my finger on, right, the anal verge, and just telling the patient I'm going to do a regular exam. I stay here for a couple of seconds, and the reason for that is it relaxes the sphincter. Once I get the sphincter relaxed and you can feel it go, you then just use that as a guide because based on how the patient is stabilized, whether they're on stirrups or any other way, the angle of how you enter the rectum is going to be very different, all right? So this is like a nice guide. So I double glove my right finger, and then I can easily pull that second glove up and then continue with, hand that's not full of lube. Right, so now we've entered. You can see in the ultrasound view here, this is a coronal view, and this is a sagittal view, right? The urethra is right in the middle. You can see the different zones of the prostate, lateral, peripheral zone, transition zone, and anterior, okay? This is the apical horn. This is where we do our first biopsy, which is the paramedian apex, right? That represents the peripheral zone right at the apex. So once I go in and I settle in and I can see it, I give the patient some local anesthetic. So where do you go with the local anesthetic? You can see the median raphe here. Very easily, I just turn to one side. If I want to mark it, I can mark it here, but usually it's more of a visual cue, and then over to the other side. So I look here, and then I tell the patient, I'm going to give you a local anesthetic. It's like a mosquito bite. So I move this over to the side. I come at an angle with a 25 gauge needle, and I pierce the skin right there. I have this technique where rather than just jabbing this into the patient, because this is your first encounter of the patient with the needle, right? If this is bad, everything else is downhill. So what I do is like, look, this is where the needle is going. And what that does, it gives it a sensation of how sharp the needle is and where it's going. And then I just puncture and I inject about 1 to 2 cc's. And you see this nice bleb forming right here. What this does is allows you to put this needle here, here, or here. Rather than having one specific point, I do the same thing on the other side and I tell them, right, we're doing the other side, and I push, right, rub on it and tell them this is where the needle is going, push a little bit, and then inject 1 to 2 cc's, right? And you should see that bleb up. Now, if you're doing a targeted biopsy, this is a good, or a fusion biopsy, this is a good way or a good time until this local anesthetic starts to settle in to actually be able to scan the prostate and then be able to overlap the MRI to your ultrasound image. Okay, so this is a good respite for the patient, for them to get used to the probe there and also let the local anesthetic sink in. Say we've done, this is a non-fusion biopsy. Again, my assistant hands it to me over this way. I pull it out, and that way I have that sharp point. So I'm going to start now with the left side. Bevel is up. I focus on first getting it through the actual applicator. So again, there's a sweet spot there, right? So don't push into the patient. Pull it back a little bit, let the needle come through, and then once the needle comes through, marry the needle to where you want to go and push in, and then just give it a little bit of a push, right? Once it's in, see how clearly now, because everything is aligned, you can see that actual trocar. That's very important. Now this is the trick. Now I loosen this up, right? And that's a little bit weird, right? I like to use the actual angulation of this to give me an idea of where I'm going, all right? So I can see this. I pull back a little bit. First thing I'm going to do is give the local anesthetic, okay? And so the local anesthetic, I'm going to have one of those spinal needles. Every institution uses it differently. I actually use about 20 cc's overall. So I like to use about 5, at least 5 to 8 on each side, right? So I place this in, and then I move my hand a little bit up because I need to angle the needle down, right? You can see that needle angling down, and then I pass it in, and I can see it kind of go, break through where it needs to be. Okay, there it is, and then inject about 8 cc. So you get through that denomvasous fascia, get posterior to the prostate, and kind of get at the apex of where that denomvasous fascia and the prostatic capsule is, and inject about approximately 5 to 8 cc. So you see exactly where the needle went there. That's the perfect location of the needle of where you want it to be. There it is. Needle is in. And so you don't see the needle, just angle it just slightly a little bit until you see the needle, and see how my finger is now guiding where the needle is going, and then injecting about 8 cc's in there, okay? I got my local anesthetic in. It's preferred to count for about 30 to 60 seconds. You have to let it settle down. It's not immediate before you do your first biopsy. For a patient that's biopsy naive, now my team does this for me before I even walk in. They let the patient know the sound of this. This startles them quite a bit. I tell them it's like a nail gun. It doesn't hurt as bad as a nail gun, but it definitely sounds like one. All right, this could cause quite a bit, especially if you're doing targeted fusion. They'll move away, and then you're going to have to do all that, okay? So I let them know that this is the sound of it. Right, so first I'm going to do paramedian apex. That's the horn we saw and talked about. So what I do is I pull back, make sure that this is free. Okay, look at how the needle now can move. I can use this needle to push down, or if you want, you can just guide it with your finger. Needle goes perfectly in. I wanted to see that anterior horn. See that anterior horn? And then I twist a little bit to get there. Needle goes in right there and fire. Okay? And you can see here the actual color. We've color-coded different areas. So peripheral zone is actually blue. I don't know if you can see this, but this is actually blue, right? So I've hit the peripheral zone. The next one is going to be same thing, but paramedial posterior, right? Or base. So I go slightly lateral to what I need to be. Make sure I can see that needle or the trocar once again. So it's right there, right? Angle this a little bit lower down. And in some thin patients, you can actually use the needle biopsy gun to actually guide this. And angle it a little bit. And I push in, and I want to get all the way posterior, right? So the needle goes in. You'll see the needle show up on the other side. There it is. All the way posterior over there, right? And boom. So the needle tract is right here. This is what I'm hitting. Okay, so it's deeper in there. It should also show up as blue and partially red. So that red means I'm hitting part of the base where the seminal vesicles are coming out. So this is a perfect biopsy. The white is actually a little bit outside the prostate, which is where you would possibly get that perineal tissue. Next thing I want to do is I want to go back. So see how I can maneuver this in the patient's body? They don't feel this, but look at the ultrasound. I haven't moved the ultrasound up, down, left, or right. I haven't torqued it at all. Perfectly stable. I'm actually holding it with 2 fingers if I need to. And if I need to push forward, I'm pushing forward and guiding this. Now what I want to do is I want to do the base anterior, or what we call the posterior apex. So if this is the prostate, I want to go further back, all right? I want to guide that trocar down, right? So the trocar goes back a little bit. I'm going to guide that trocar down. See how I'm guiding that trocar down? And then I push in a little bit, and you can start to see that I'm getting into the base. Now, I feel I'm getting too far outside, so this gives me that trajectory, which is right here, right? That perfect trajectory, which is right there. I'm getting it where I want to get it, and fire, right? This should be also a pure blue here, and that's it, right? That's the core over there. To finish up the peripheral zone, I go as far lateral as I can and far posterior as I want, right? So I can pull this back a little bit if I want, if it's too far in. I find all the way posterior, and then look at the tip of that trocar now. I'm pushing it in. I can see the needle. I actually pull the needle back. Do you see how I can guide it? See how much I can guide that needle? That needle on the ultrasound, so I'm moving it up and moving it down, and then I go posterior, right? Now I want to adjust and go further back. So I can actually lift it up, go in, and I'm traveling all the way into that posterior. So I can go through the transition zone, as you can see here, to get into that posterior zone, and then almost hitting the seminal vesicles here. And that's, see, perfectly posterior, red. So this is posterior base. Now I'm going to do lateral, right? So you're slowly, one of the things you need to learn for if you're moving from transrectal, you're used to twisting this probe. I rarely twist it. Moving left and right is moving sideways, okay? So I'm moving all the way sideways. Look at that plane. The prostate gets smaller, smaller, smaller. Now look at this. I can go up, down. So I like to get a little bit of the transition zone here. See that needle go in? And right here, I can actually go into the lateral. So lateral, as I recall, in this is yellow. See that? Finally, the most difficult one that none of us get is that anterior zone, right? So I go back, find the urethra, right there in the middle, and then back up a little bit. Now watch this. I can pitch this as far up as I can. I use my finger to push this all the way up. You see the trajectory of that needle? It's going to hit purely anterior. See where the needle is going? The needle is actually right here. Now, if that's not enough for me, I back up and go a little bit higher. If it's a large prostate like we had mentioned, this is where you take this out, right? You do a little bit of adjustment here where you pull back, take it higher, pull back in, and then tighten it up just a little bit where you want it to be perfectly angled up. It takes a couple of seconds, and then you can now pass this needle guide or the biopsy gun, and you'll start to see where that needle is going. Look at that. You're very perfectly anterior. Again, release this a little bit, push it as far down as I want, and you see that? See where the angle of that prostate is and where the needle is? I can rarely get up there with any other platform. There you go. And I haven't moved the probe at all. This should be, if I recall my colors, green. There it is. I don't know if you can see that. That's a little bit green. That's perfectly how we do one side, right? Probe didn't move at all, or even minimally, okay? And you can change your angle. You can do a height adjustment, you can do an angle adjustment without really needing to move the probe at all. It is very simple. And just as a guide, when I loosen it, loose to me is 1, 2, tighten is 1, 2. See how easy it is? But realize when you're loosening it up, see how the middle moves? Get that again. This sometimes malaligns it. You just need to overcompensate by turning it. That's just the normal hinge mechanism. But see how easy it is to loose and how easy it is to become tight. Now, if I'm moving over to the other side, this is a very important part. I bring it back center, tighten it up, okay? And then I pull the needle out, because if you pull it out when it's loose, you can actually pull the whole thing out. Turn to one side, keep the needle where it is, and then aim for the bleb on the other side and just engage. And then push the needle in slowly. And that way, I loosen it up again, 2 turns, and now this perfectly can be loosened just like the other side, right? It's fairly, you have to get used to doing several things. You have to get used to moving this up and down, okay? And you kind of have to see it from the edge here to know where it is. You have to get used to tightening it and loosening it up very easily, right? The other thing is sometimes you have to move this. So sometimes in the middle of it's completely malaligned, like sometimes I put it onto the contralateral side and then I turn around and find that it's really too far and it's stretched. I'm not going to poke the patient again. All I do is loosen this and then turn it, right? Turn this to line it where I want it and then put it back in. It's fairly easy. Takes a couple of seconds. You just have to be used to using the knobs in different ways. So if you realize, we only punctured the patient's skin twice, one left, one right. Now, again, given the versatility of this platform, that's all you should do. The moving needle inside the patient's kind of, subperineal area does not hurt at all, right? Because you do it short of the muscles. Now, sometimes a lot of people kind of need to move the needle up. When you're moving the needle, you're not moving the puncture, right? The puncture of the needle is right there. You're just moving the trajectory of the needle to how it is there. So it's just giving you more range here to pivot up or pivot down, right? So this way, you only need to puncture the patient twice. Sometimes when this trocar is quite long, sometimes in a really thin patient, when you're all the way in and you're into their muscle and sometimes onto the prostate, you see a bit of bleeding here. Yeah, just pull this back a little bit. Still works, right? It's just going to stop bleeding so much because you're not really into muscle or into prostate. So once you get the hang of this, I'm 100% sure that every single one of you will adapt to this device very differently. That's the versatility of this device, is that some people do it when it's loose, some people do it tight and move it up and down. There might be even a third or fourth way of doing it. So it's really up to you. It's just know how the platform works and then be able to adapt to it based on what you prefer and what is best for your patients. In this technique, I'm going to actually move and height adjust every single time. So for this, you want to start by going down on, rarely does anyone use the first one. The second one is kind of appropriate to get your local anesthetic and then locking that in, okay? And so at this point, you have to make sure it's straight so the angle of the needle is perfect. And like I said, when you're shifting from one side to another or even primarily inserting it, I want to make sure that you place the needle with the bevel up and just push it through the device, right? And just have it stick out and use that to kind of pierce the skin first and then apply the needle and let it seat completely in. That's really the best way I found, rather than, putting it in and then trying to pierce and the needle and the skin gets stretched. You're actually piercing through the skin with the needle sticking out. Then you're actually move the device in so the patient doesn't feel the ultrasound's going in, the needle's going in, there's just too much sensation happening at the same time. So now I've kind of completely, you can see here is actually the trocar. Here is the prostate. This is the anterior horn. So I go all the way lateral, and as we agreed in transperineal approaches, you move the probe left and right by swinging left and right, not twisting, okay? So this goes in, and this should hit the perfect trajectory of getting that. See how the trajectory of the trocar is? The needle is naturally going to follow that trajectory and get into where you need it to be, and then you can start injecting your 8 cc's of local anesthetic, and you see that area flash, kind of fill up completely. Now, one of the things I want to reiterate when you're going in with the local anesthetic, you want to go in very slowly. So you want to tell the patients, I'm coming in with a needle, and then you want to slowly get in. I do a little bit of a trick. As soon as I hit those pelvic muscles, right, I start to inject so that it kind of opens up a space, and then you push in. It does burn a little bit, and then you continue injecting as you go in, and as I come out, I inject. What that does is it numbs up the muscles themselves, not only the prostate, because that's your trajectory that you're going to go in and out. All right, so the patient now is numbed up completely. All right, so now we're going to start by doing the paramedian apex, which is this anterior horn right there. You can see the trocar is perfectly aligned with where you go. And now we're going to do our first biopsy. So perfectly goes in. Now, I know a lot of you think about how the bevel of the actual gun goes in. That's of minimal importance when you have this device, because it's actually pointing exactly where you need it to point, and you can change that versus it being a fixed point. So the needle's going in. I'm going to start to find the needle. You can see the tip of that needle right there, right? You can see the tip of the needle here. And then what we're going to do is we're going to take that first biopsy. So again, this is a color-coded model, so this should be perfectly blue. And there it is, perfectly blue. All right, let's get some white here. Okay, next one is going to be paramedian base. So I go slightly lateral, push a little bit in so that I can get to the base of the prostate and follow the same exact way. You'll see the needle going in, right? You can see the tip of the needle right there, right? So this is where I want to adjust a little bit, right? So I back up a little bit, loosen this, push this down, tighten it up a little bit so that I don't hit outside the prostate, and then I can biopsy again. There. So the base in this model is colored red. So this is kind of posterior part where the seminal vesicle is and the peripheral zone of the base. Okay. Next one is going to be apex posterior, and for that we go all the way lateral until we see kind of the seminal vesicle, and then what we do is we go into the peripheral zone in the anterior component of it. So all this anterior zone is actually, all this is giving us the same. I haven't changed the position here yet. All I'm doing is just making sure I define my trocar, right there. See the tip of the needle right there? I'm going to push in a little bit. That's the tip of the needle right there. So that's the anterior half of the peripheral zone. That's the biopsy. This should also be blue, slightly red. Another very important thing here that a lot of you realize I use this device quite a bit. So naturally, the needle goes perfectly into this obturator. That's usually not the case. There's a little bit of space between here and where the needle actually holds. And a lot of you are going to catch on, see, I'm catching on the needle, right? You realize this thumb here is for a reason, right? So what I do is I take this and settle it on my thumb and then aim it directly. So I hold the biopsy gun this way. I don't hold it this way. There's less control if I hold it this way. I hold it this way and use the button in the back to actually go for the biopsy. So prime it, and then I hold it like a pencil, right? Rather than, just grab onto it like a racket. And then my thumb is on that, and look how it kind of naturally aligns on my finger. And what that does is it just provides this straight track for it to go right into. So if you realize that you're kind of snagging on this part a lot and pushing quite a bit, just use your finger to kind of align it perfectly so it smoothly goes in. Because this, if you're pushing on this, it leads to a little bit of disturbance with the patient. So back to our biopsies, I can see the trocar going in very perfectly, the needle, see that needle there? And here, if I continue on this trajectory right here, you will see how I'll start to go into transition zone, right? Very simple solution. Loosen this up a little bit. Even use your finger to guide this down, and then see how now we're skirting perfectly all the way along that peripheral zone, all the way back. Look, I can guide it all the way almost to the seminal vesicle, right? This is, you can do real-time guidance. And as you get used to this, see perfectly red. This is full points in my scoring system of this model. That's perfectly posterior peripheral. Now we're going to have to change things a little bit, right? So I'm going to put this on here. Now I need to go a little bit lateral, right? So I'm going to back up a little bit. I'm going to swing all the way lateral, okay, until I get all the way to the lateral here, okay? Now I want to, rather than keep hitting the peripheral zone, as you can see I've hit it before, I want to hit somewhere higher up. So very easily what I do is I loosen this, make sure this is all the way in, use my finger to pull this back, go up, and just go snap 1, higher, and you can lock it in. Okay, now if you look at where I'm going, I'm actually hitting partially lateral, but also hitting that peripheral zone. See, trocar is here. This is the lateral versus me hitting this here. So you adjust and get better biopsies, right? Again, see, it snagged again. So I put my finger here and just align it beautifully until it goes in. Sometimes just spinning it this way makes a lot of sense. So see the needle going in, boom, right? So that's perfectly where I want to get my biopsy. Another perfect yellow. So we're getting, great points on this model because lateral is yellow. So this is perfectly lateral. Okay, now for what people assume is the most difficult one. Now realize throughout the entire process, the torque of the ultrasound is left and right. There's no up down, right? When I used to use this before, I used to be doing this to get it up, this to get it down. That really hurts the patient. The probe only moved minimally left and right, and if you want, you can even twist it a little bit. So this is the prostate. This is my anterior zone. How am I going to get a trocar that's here all the way up here? Very simple. You loosen this again, right? Back up the trocar a little bit, and then you use both fingers to lock it up and then go as high up as you could go, right? So push it back, go up the ladder, as I would say, and then lock it in. So I'll adjust it one more time where I go up one more time, right there. So that's the highest point I can get it, while at the same time, I try to torque it up as much as I can. Okay, lock it there. Now, if you look at the trajectory of the trocar, it's going straight. Now you back up a little bit. You're not torquing, you're just taking the ultrasound out a little bit so that you can pivot it in. Now just be careful because you're going to bend your biopsy needle a little bit here, so you have to go in a little bit slowly. There it is, needle coming in, see that? And now this should be, as I recall from the model, all green. Yep, and there we are. There's green there. That's perfect. So this is an example of how you can, and then at the end when you're done, you just pull it out or pull the whole thing out, right? And you're done. So it stretches the skin a little bit, but the perineal skin is quite stretched, but you can go from second all the way up to fifth. Sometimes if you have a larger prostate, I would suggest you start on the third, so you can equally go down and up, but this is using the ladder function, in addition to using also the function where you can kind of guide the needle also. Some people always hold this way. So they loosen this up, and then with their thumb, they can guide it up and down. It's sometimes a little more cumbersome with a large patient, but this is also a way that you can exclusively just move it up and down without needing to lock it in and out. Luckily, I'm left-handed, so this is usually how I would hold my ultrasound.